I'd like to introduce the next panel and the facilitator for that panel, and that's Christine Wilson. She has more than 15 years of experience in local, national, and global healthcare, and she's currently the president and CEO of the Mid-America Coalition on Healthcare. And please invite her and the panel to the stage. Thank you very much.
Thank you. Well, this session we hope to be a little bit different. It's going to be very informal, and we hope to engage the audience in a lot of questions. I'm going to introduce my panelists and let them tell you a little bit about their role and their work with healthcare data innovation, what they're seeing from an entrepreneurial standpoint within the state of Missouri, potential opportunities and challenges. So we'll do a little dialogue and some Q&A up here for about 15 minutes, and then at that we'll open it up to the audience for questions. I'm Christine Wilson. I'm the president and CEO of the Mid-America Coalition on Healthcare in Kansas City. We are a not-for-profit business healthcare coalition with about 60 members. We represent about 450,000 covered lives in the Kansas City metropolitan region. We are a multi-stakeholder group. We consist of employers, hospitals, health plans, physicians, public health community, and other not-for-profit organizations. Really, our mission is to improve the health and well-being of the workforce and the broader community at large. My prior background was in communications consulting, and I worked a lot with pharma companies and biotech companies, really trying to get products to market and to use healthcare data to establish the unmet need, use healthcare data to communicate with patients, patient advocacy. We really started moving into channels, social media channels, because that is where individuals go for health information, whether it be good or bad. They do engage in social networks, in the internet. And then from the Employer Coalition standpoint, we have been using a lot of public health data in a project we're doing around obesity in Kansas City, and using healthcare information from employers, from public health agencies to look at issues such as the food desert. How can we positively affect social, environmental, and policy change to impact obesity rates in our community? And then with the employer community, looking at pulling all the different data sets together, and how can we pull that information together, synthesize it, and really use it to impact measurable change within the employed community? How can we devise value-based benefits and benefit systems and incent employees and their dependents to take the desired outcome? So with that, I'm going to introduce the individuals this afternoon. We've got Michael Long, who is the chairman and CEO of Essence Group Corporation and Lumeris. We've got Jeff Stolte, who's an investment associate with Ascension Health Ventures. We've got Louise Probst, who's the executive director of the Midwest Health Initiative. Another hat that she wears is she is also the CEO of the St. Louis Area Business Coalition. And then we've got Dr. Miller, who is the senior vice president and chief medical officer for Express Scripts. So I'd like to start with you, Michael. Tell us a little bit about yourself and your interface with healthcare data.
Okay, the first thing I'd like to say, thank you for having me, and Todd, you are doing God's work. Thank you for what you're doing. I'm either one of the Pied Pipers of healthcare or the Don Quixotes of healthcare. I'm not sure which, but I have. You said that if I have interesting histories to tell. Boy, do I have stories to tell, but there's not enough time here today.
In 3 minutes.
In 3 minutes, the longest I tell it, 3 minutes, right? No, I have. Been involved in a number of initiatives, launching a company called Healthy on WebMD, which was a serious effort to try to solve the problem we're talking about today. We raised about $2 billion, built an incredible cloud-based computing infrastructure, aggregated tens of millions of consumers on WebMD, connected physicians through MDON, and then learned a very valuable lesson that you need information. Accountable care and bending the cost curve of the healthcare system and improving clinical outcomes requires transparency of information. You cannot do it otherwise. Our movement towards accountable care is all about transparency of information, getting it to the right person at the right time with the right information. And learned a valuable lesson that 12 years ago, the payers had the best digital data in healthcare, and they became very anxious about our model. So they decided not to cooperate with the model. as far as providing information to what we call the point of clinical thought, which is that doctor-patient relationship, empowering it with better information to improve decision-making. It's a pretty simple, audacious, proved to be an audacious goal. We created some interesting companies, WebMD, MDON, and 4 or 5 private companies, and the shareholders did fine, so don't feel sorry for the shareholders. But we didn't bend the cost curve of the U.S. healthcare system, and it was $1.2 trillion then, it's $2.6 trillion now. So you're looking at probably the person that's incurred the biggest single personal failure in his career. And so we're back. We're back to try again. That the world's changed a bit. We've launched a company here, a little company here in St. Louis, founded by John Doerr, a venture capitalist native here of St. Louis, and his brother, Dr. Tom Doerr, who's here today. We're about 500 people. We've been at it now for about 5 years, trying to build an information architecture for accountable care. We actually provide our partners and those that collaborate with us with an accountable delivery platform. We're about 200 engineers, and we think we've got some of the best engineers. You're absolutely right, Todd. You can only do this with great people, and we're back to our audacious goal of improving clinical outcomes and bending the cost curve of the U.S. healthcare system, and we hope to be a player. Thank you for having us.
Jeff?
Sure. So I'm Jeff Stolte with Ascension Health Ventures. I'd like to begin by thanking Todd and Ned and the Missouri Foundation for Health for hosting us here today and including us on the panel. Very interesting collection of organizations, individuals, affiliations in the audience, and I've enjoyed the day so far. For those of you who don't know, Ascension Health is headquartered here in St. Louis. We're the nation's largest Catholic and not-for-profit healthcare system in the United States, which is working to transform healthcare by providing the highest quality of care to all, with special attention to those who are poor and vulnerable. And our mission-focused hospital system and health ministries employ more than 120,000 associates across the United States, serving more than 1,400 locations in 21 states and Washington, D.C. Ascension Health Ventures is a wholly owned subsidiary of Ascension Health, and without going into too much detail, our function is really to look for the entrepreneurial companies that are diamonds in the rough in the U.S., and we look nationally for entrepreneurs, ideas around medical devices, healthcare IT, healthcare service models that are fledgling entrepreneurial organizations looking for capital to grow. We focus primarily looking at opportunities that have the ability to transform our healthcare system from the inside out. So our 4 investors are Ascension Health, Catholic Healthcare West, now known as Dignity Health out in San Francisco, Catholic Health Initiatives in Denver, and Catholic Health East in Philadelphia. So all told, the organizations that we work on behalf of represent over 200 hospitals, over a couple 100,000 employees, and north of $25 billion in net patient revenue a year. So we like to think of the organizations that we represent as a small microcosm of healthcare. And in that sense, a lot of my work is talking to entrepreneurs, reading business plans, understanding what innovation is coming into the marketplace, and then taking that and translating those stories into the thought leaders, managers, physicians, nurses who work in our hospitals and health systems to understand what their needs are and how those innovations can help them practice and improve healthcare, both safety, efficiency, and all the themes that we've heard today. Clearly, one of the themes that we're hearing more and more about over the last few years is the leveraging of data, utilization of data to better manage our facilities, and to empower consumers, create new partnerships that will, to Mike's point, really enable a more unified ecosystem of healthcare providers that are truly delivering value-based care. I think many of the unique challenges that we have from a data perspective is that a lot of the historic infrastructure and investments have been made to support a fee for visit infrastructure or model of healthcare. And as we move to a value-based system, I think we're going to see a great deal of imperative and a great deal of innovation around how to better share data, work with our partners, and deliver more successful healthcare. So happy to be here.
Louise?
Great, thank you. I also want to begin by thanking HHS and Todd and the folks from the foundations for making this possible. I'm going to talk today about Midwest Health Initiative, and one of the things that we always remind ourselves to do is take time to recognize and celebrate the success of others, and that's been a great opportunity this morning. I work close to this space, and Todd, I learned a lot of new things today that to be really enthusiastic about. So I think it's a great way for all of us to end the week and start a weekend, and so it's fun to kind of stop and celebrate the progress we're making in healthcare. I'm here representing the Midwest Health Initiative, and I suspect a lot of you might be familiar with the Business Health Coalition. We've been around for about 30 years. But a few years ago, we started with other partners, our health plan partners and others, a new nonprofit community benefit organization called the Midwest Health Initiative. And really, the Midwest Health Initiative was founded and designed as a place where different perspectives, the perspectives of people that receive care, provide care, and pay for care, could come together and really work on identifying priorities and opportunities to improve health and the quality and affordability of health care. So our mission, pretty clearly states that we provide a forum where trusted information and shared responsibility are used to improve health and the quality and affordability of care for our region. Some of the people that are stakeholders that are represented on our board and around the table are consumer perspectives, labor representatives, both public and private sector employers, hospitals and physicians, organizations and individual physicians and health plans, Express Scripts, and public health. So we think we have pretty much all the stakeholders there working together. One of the early understandings, I think, that got this started were some of the employers in the Business Health Coalition. Several years ago, were really looking at what they faced, and they recognized the challenges, or those that saw the world as Todd does, the unprecedented opportunity before all of us, and to really work together to improve the affordability and the quality of care. And clearly, I think they recognize, and we all recognize, and I'm sure everyone here does, is that no one can do that alone. There's no one entity, even the federal government, that can fix healthcare. It really does take the shared responsibility of everyone. We're all, part of the problem. We all need to be part of the solution. The challenge is there really wasn't any place for us to come together and share information, set priorities, and work together to do that. And so we really believe that healthcare is reformed community by community with the right policy levers and information and support from government. And so that's really what we're trying to do at MHI. Another shared belief that pulled the partners of MHI together is an understanding and a belief in the power of information. We talk about unleashing information, and I like your word of liberating it, but really using information for so many different people can take that information in their own sphere of influence and really use it to improve quality and affordability. And so the goal was to create an information source in our community that could be one information source, not the information source, but could be knit together with other information sources to really empower so many different people. And we realized that there are a lot of opportunities to improve really small pieces of care, and we need to improve little bits continuously all the time, and that the information would really allow that to happen. So we have pulled together a data asset, and I want to recognize our health plan partners that were our founders and that contribute their data, and their Anthem, Coventry Health Plan, and United Healthcare, and Express Scripts as well, and some other parties. And we pull that information together, much like you talked about the federal. We take all the private healthcare information off of that, but we put it in a data set together to be able to be used from a population health perspective, inequality and affordability, and really empower others to use the data. And so that's the goal. That's what we work on. The initial data set had a little over 2 million lives, and we're soon going to be up with a new data vendor, which will bring us a physician portal and some other opportunities so that we can more effectively engage with our clinicians in the community. So that's a little bit about how we have the data and the data that we do have, and the mission of the Midwest Health Initiative.
Dr. Miller?
Well, like everyone else, thanks for having me. It's really been an exciting day. My name's Steve Miller. I'm the Senior Vice President and Chief Medical Officer at Express Scripts, but prior to that, I was a basic scientist and a transplant kidney doctor at Washington University. So I've been a data hound in healthcare for now 30 years, both in basic research and then applied clinical research. As I grew as my career developed, I became an EVIL administrator at Barnes Jewish Hospital and Washington University. And at that point in time, had the opportunity to spearhead many initiatives, including putting in electronic medical records, clinical CPO systems, e-prescribing, and other things. And so I have a lot of battle scars of what works and doesn't work in trying to wire healthcare. 7 years ago, I finished my transformation in becoming EVIL, moved to the private sector to Express Scripts. And one of the big draws there was actually we sit on 45 million people's pharmacy data. And so the amount of data we have, and we're currently trying to merge with a competitor of ours, Medco. If we do that, we'll have the pharmacy data for 100 million Americans who are commercially covered in the United States. And so it would probably be one of the largest healthcare databases in the world. But we do a tremendous amount of research on this, looking at how we can influence people both positively and negatively to have a better experience with their pharmaceutical benefit. So what does copay design do to actually change people's adherence? What can we do to drive better adherence? Probably the funnest thing I've done in recent past is I actually hired a bunch of people much smarter than myself, pretty low bar, from the credit card industry, and we've created predictive models. So I know prior to a patient taking their first dose of a medicine if they'll stay adherent to their drug or not. This allows me to actually tailor communications to them, so those people who I know will be adherent, I don't have to send mailing to, which would be spam mail to them. Those who aren't going to be adherent, I can actually reach out to before they develop the bad habits of non-adherence and try to get them to be adherent. And then on top of that, because we're so involved in e-prescribing, I helped form a company called SureScripts. SureScripts has grown to be the #1 e-prescribing routing company in the United States. We're hooked up to over 250,000 doctors, all 65,000 pharmacies, all 5,500 hospitals. And so over 90% of electronic scripts actually flow through our pipes today, which is a phenomenal source of information also. I just want to leave you with 5 different learnings from the scars of all the failures I've had, and that is, #1 is you got to know where you're at. Do you want to be on the leading edge, the bleeding edge, or a fast follower? Many times I have been burnt by trying to be on the leading edge with either technology that wasn't mature enough or on the fast follower only to be blown by someone else. #2 is that you have to have, and this has been a theme today, a sustainable model. Just because you have data doesn't mean you have knowledge, and just because you have knowledge doesn't mean anyone wants to pay you for it. And so you have to figure out how you're going to have a sustainable model. The third is that great ideas are often not good enough. We built a web portal for our clients that won us tremendous number of awards. This was an award-winning portal, really spectacular, and not one client uses it. So while the techies loved it, it could win Datapalooza, it couldn't win a client. Fourth is that the quality of data really matters. Many people have touched on this. The great thing about pharmacy is the quality of the data of pharmacy is spectacular. The quality of data with laboratory is spectacular. As you move further down the spectrum, you look at doctor-entered data, it gets more mediocre. You look at patient-entered data, it gets even grayer than that. And so the quality of data that you're working with really is crucial. And finally, you have to be willing to develop strange bedfellows. So when we develop SureScripts, we have our competitor PBMs involved, and we have all the pharmacies that we compete against involved. And so everyone at the board meeting hates each other on a day-to-day basis. But we all pulled together because it was the right thing to do for the United States to be able to promote e-prescribing and to get the data flowing. And if we had not done that, we probably would not have the uptake we had today. And so you have to be willing to get in bed with some very strange bedfellows if you're going to make data transparent and useful. And thanks for having me.
Welcome. Okay, now we're going to open up some questions with our panelists. Louise, we know that healthcare quality data is very important to consumers. We know that consumers typically go to the internet for healthcare information. I just heard a statistic at a conference last week that on iTunes there are 25,000 healthcare applications that you can download, and I'm sure those are being added to rapidly. But how can we take this healthcare quality data and make it usable for consumers? I know one of our panelists talked earlier about the timeliness of it, making it relevant, and making it actionable. So I don't know if you have some thoughts on that.
I think that is the big piece. How do we make it usable to consumers, and how do we make consumers understand that they need it and that they should be using it? I happened to be at a conference last week where there's a lot of discussion around consumers, and a lot of researchers were very concerned about a couple of things that we all probably should think about in helping consumers understand. And one is that more care isn't necessarily better. And so maybe they want to look and think about the treatments, that oftentimes there are differences. Treatment options, that there are a few diagnoses that are truly an emergency, and that they should take the time to get good information about the risk and the effectiveness of the treatments. And so I think understanding that would want people to use different technologies or access information, to think about that. And then also this whole issue of thinking that all they have to do is understand the cost, or higher cost is better quality. And that's a concern of a lot of people that were there trying to develop consumer information tools. And I think that's, to be understood. Anytime we can't understand or differentiate the quality of a product, we tend to use cost as a proxy, whether we're buying champagne for someone or not, And so I think, one of the things that might be helpful, although a little bit challenging, is to help consumers understand that there is not. Research has shown there's not a connection between cost and quality, or at least today. But also in healthcare traditionally, because we've paid for complications, choosing the higher cost could be a riskier decision. So somehow we've got to get consumers to realize that there are differences, and that they need to look at the differences in the effectiveness and the risk of treatments, look for signs of quality, and not substitute cost as a proxy for that. Because otherwise we won't be able to reward the providers that are able to provide a quality product at a lower cost, and that's what we need to reward.
Thank you. And Dr. Miller, Google Health was launched with lots of fanfare. Thought there would be huge uptake, and we know now that that is actually going to be shut down. What do you think we can learn from that case study in helping us move forward and in building information technologies that are actually going to get quick uptake and be useful?
Yeah, so as the king of failure, I guess I'm appropriate for this question.
I thought that was me. Happy to share the podium with you.
So actually, when Google Health was being launched, obviously because we sit on so much data, Google Health approached us to participate, and we actually predicted that it would not be successful, and had told them that, and they, of course, could not believe that Google couldn't succeed in anything. And the reason is that people don't think about their health continuously. And the trouble is, updating your own health on a website continuously is a tremendous amount of work. And going out there and actually retrieving all your data, bringing it onto the site. And so if you think about it from a systems design, ergonomics type of standpoint, it really has to be what works for people in their normal life. And so the reason so many of the great things work is that it's just intuitive. Apple is elegant design. And so people don't have to read the instruction book on how to use an Apple device. But when you were using Google Health, it almost required an instruction book to understand how you were going to go out and get your own data, how you were going to store your own data, and then you were worried about both the privacy issues and all the pop-ups for advertisement. So based on all those things, what our takeaway lesson is if something's really going to work, it has to be designed to be used in your daily life, and if you have to have too much effort to it, it's not going to be successful.
Thank you. I think it has to be very intuitive as well. Jeff, in your role, you review a lot of business plans across not only the state of Missouri, but nationally. You meet with lots of entrepreneurs. Where are you seeing the new ideas coming from and some of the new innovative ideas that you've actually had a chance to review and possibly even fund?
Sure. Happy to share. And I think, starting where Steve started, actually one of the key things that we look for are solutions that fit into the existing workflow of the end user. And again, our organization primarily looks at solutions that are targeting healthcare providers, hospitals, physicians, nurses, clinics, basically any organization across the continuum of care. I think there are a couple of innovative areas where we see a lot of activity. One is, again, there is a long legacy, despite the fact that people talk about the lag in healthcare IT investment in healthcare. There's a long legacy of investment in information technology systems across the myriad facilities that we practice in. The challenge is they've grown up in silos and really are very designed around very structured data. When healthcare is becoming much less transactional and much more about value and integrating data and integrating a variety of different health streams. So one of the areas that we look at is what are entrepreneurs and innovators able to do to that data to make it more usable. Todd talked about releasing it in a very machine-readable form through API and that sort of thing, and that's clear. I think one particular example that might illustrate this, I think by some of the data that I've read suggests that about 80% of the care that's or 80% of the information about care that's documented in the hospital is in unstructured format, so blobs of text, paragraphs, things that are not picked from a drop-down list or entered in very discrete data. That type of information is very hard to analyze. However, 80% of the information about our care is being stored there. So there's an organization that grew out of Carnegie Mellon University called M-Modal, which some of you may be familiar with, which is taking natural language processing technology and applying it to EMR data stores, particularly to unstructured text, and it's able to read through text, map clinical concepts, and then enter those concepts into more of a database structure so that they can be added to the 20% of information we have access to in structured form to then make a more complete clinical record that we can then look at innovating with and using that data to build intelligence from. So I think transforming data into usable, actionable information is a key theme, and we've seen a great deal of innovation around that. Within Ascension Health, and I think within many care providers today, we're looking for solutions that help us to take not only clinical data and analyze it, and we've heard a lot about great outcomes research here today, but really marrying that with financial and operational data as well to get a full picture for how we're delivering healthcare and how effective we are at doing that. It really, again, gets to that question of delivering value for the dollar being spent on healthcare and understanding how to do that in the most effective way. So marrying different data sets that traditionally have been segregated is another way. I think the one other point I would make here is with the proliferation of mobile devices, and Todd talked about his iPhone, and I got one recently too, and it has changed my life. And I've got all my notes on my I'm cheating completely up here with my iPad, so bear that in mind. But I think what we're seeing is not only the liberation of data from the large institutions where it's being created, but the collection of data from a variety of novel endpoints. And really, the individual is becoming a creator of data themselves. And you see this through technologies. Ascension Health Ventures invested in a company called Body Media, which is an armband device that basically tracks your calorie expenditure, your sleep habits, and your activity level throughout the day. So the individual is actually throwing data off every hour of the day that they wear this device. I think to Steve's point, the challenge is how to make that information meaningful and integrate it into the clinical workflow to create a more holistic view of patient care. But those are a couple of areas, and I can maybe touch on some others later.
You've talked about several areas of innovation. One of the things that we've heard from folks earlier today is making sure that these business models are sustainable. What other success factors do you look at when you are evaluating companies and evaluating proposals?
Sure. And keep in mind, there are various stages of investment activity. So we've heard a lot about angel funding. I think we've seen evidence of public-private partnerships here today. And I think organizations that are just starting out, have to be very capital efficient in how they grow their models. Steve and others have talked about really understanding the end user, understand the value that you're creating for someone, because just because you can take a large set of data and whittle it down to a very actionable set of information, if you're not getting that into the hands of an end user in an effective way, and really understand what their information needs are, you may find that you've developed a beautiful interface with no market. So we look for the standard things, and we look for revenue traction and a steady growth rate, a solid management team that has multiple perspectives, both from the business side but also from the end user side. Certainly from a sustainability standpoint, again, understanding where the funding is going to come from. I think there are amazing opportunities in healthcare right now with the alignment of incentives across the payer and provider market to now finally drive toward value-based reimbursement, which should enable us to look at some of these innovative solutions in a different way than we had before, when a hospital may put them in play, but the value accrues to the payer. There have been a terrible misalignment for a lot of years, and I think we're moving toward an era when things will be better aligned. But those are a handful of success factors we look for.
Great, thank you. And Michael, what new business models do you see emerging in this new era of accountable care?
Okay. First of all, I'm an optimist. And I actually believe we're going to fix the system this time. I really do. And I'm a disciple of Dr. Clayton Christensen from Harvard. How many people know Dr. Christensen and followed some of his work? A couple of his principles, I think they're relevant here, is that, first of all, he talks about destructive innovation. And I know destructive innovation doesn't seem like a positive thing, but Dr. Christensen, if you spent an hour with him, would convince you that it is. And he talks about disruption of business models. The reason that's good is because it makes things more affordable and more accessible. And second thing he he suggests is that disruption occurs when valuable expertise is commoditized. And that's painful for experts in this room, and to hear those words. And he also says that some of the most expensive failures is when that the focus is primarily on the technology as opposed to the underlying changes that have to occur to the business models. And so those are all, I got the scars on my back by ignoring those three principles. So there are 5 trends. You know, you talk about 3 things or 5 things when you're with an audience, right? That's the way we're all trained. The 5 trends that I'm excited about in healthcare that have only been evident, I think, just in the last few years, and frankly, I think are outgrowths of 3 things. First of all, I think we can, regardless of whether you're Republican or Democrat, when President Obama focused on healthcare as his #1 agenda item, it changed the conversation in the country and focused it back on healthcare. And that's whether you're a Tea Party or not. You talk to almost any consumer on the street now, and you say, what are the problems in the country? Healthcare will come up in the conversation. The second overall trend is that it did, in fact, contribute to breaking the balance sheet of the country. And we've got to fix it because our economic and national security is dependent on it. So those are those. And then the couple of other trends that have gotten my attention and why I'm excited and I'm kind of back in the trying to solve this big problem, this audacious problem, is, first of all, is that we're entering an era of big data. And it's going to make a big difference in healthcare. And because healthcare, other industries have been playing in big data for a while. Healthcare hasn't been able to play because our data's been siloed, that was digitized, but a lot of data's been in paper files. And the government's now paid us $20 billion to get those paper files digitized. Now, unfortunately, we're going to create 125,000 ambulatory EMR islands of automation and about 1,300 acute care EMR islands of automation. So we're going to have to integrate this data, and we're going to have to put intelligence into it. But it is a remarkable era of big data. How many people know what an exabyte is? Okay, I knew Todd would know. Okay. I mean, you've seen the analogy. There's a good book that just came out. I picked it up. I'm going to read it on the plane tonight about abundance. But I've been involved in big data in the geophysical science industry, where big data matters a lot. It's when you're imaging the Earth and measuring, scientifically measuring Earth signals. But an exabyte is 1 with 18 zeros. If you take the history of mankind from the beginning of mankind to 2003, we generated about 5 exabytes of data. If you computerize or digitize all the images and everything that was written. In 2012, we're generating about 910 exabytes. And now the prediction is in next year that every 10 minutes we'll produce 5 exabytes of data, which is equivalent to the beginning of mankind to 2003. When you got that much data, you can actually see patterns and you can learn. You have learnings that were not possible before. The second thing, this major trend, is connectivity. It is almost ubiquitous now, and it is egalitarian. It's creating an egalitarian planet where people are not disadvantaged because they don't have access to information. The third thing is we understand now much better behavioral economics and the influence that has on driving outcomes. And we're kind of manning up to it in healthcare, that behavioral economics actually does influence providers and their behavior. The fourth thing is we're now disaggregating healthcare services, and the services are going to the lowest cost, highest quality, most timely provider. And that's a great thing. And Dr. Christensen loves disaggregation of services. And then the fifth trend is, as I mentioned earlier, is that the country's broke and we don't have a choice. You look at the history of the human condition, we tend to try everything, and when we run out with all alternatives, we finally fix the problem. And I think we're going to fix it now because we don't have an alternative.
Great, thank you. And just to plan in this era of big data, how can we leverage data to help physicians get the best possible clinical outcomes as well as financial outcomes?
Lots of examples of that. Let me give you a personal example. You got to personalize healthcare, and I've got my own personal experiences. I appreciated yours, Todd, with your daughter. Thank goodness Diane's okay. But we envision, if you think about this we now have digital information. We're going to have a lot more over the next 3 or 4 years with this incentives to install all these EMRs. But if I'm a 55-year-old female, let me play that role. You be my 55-year-old female, and I'll be Dr. Mike.
I'm not
okay?
55.
I know you're not. It's
Not for a
obvious.
long
It's
time.
obvious that you're not. And, but you probably, let's say you are 55. It's your mother. Your mother.
Okay.
Okay. She probably, and she's got maybe possibly a number of conditions. She's got a primary care physician. She probably has a relationship with 5 specialists. Maybe she's visited 2 hospitals, the community hospital and an academic hospital. It's highly likely if they all had EMRs that her information is in 8 different EMRs. So the opportunity with data integration, and not only integrating data once it's digitized, but integrating it into the workflow of that physician. And what does that mean? At the point of clinical thought, point of patient care, now your mother is presented to me, the primary care physician, and I'm able to now see for the first time a global unified medical record of what's happening to your mother across the continuum of care. And presenting that to the physician, not overwhelming the physician with data, which is one of the risks that we have. He's got the 7 minutes. And you can provide too much information. How do you distill that? Because you got to put intelligence into the data. You got to have the connectivity, and you got to have the data digitized, but you got to add intelligence to it and summarize it almost instantaneously for me, the primary care physician. And what's important in this new world of accountable care? First of all, I can immediately recognize that your mother is 2 years late on her mammogram. Or I can immediately recognize that she's a year late on a colorectal screening. Or her blood pressure is not controlled because she didn't fill her scripts. Why didn't she fill her scripts for blood pressure control medicine? Is it for economic reasons, or did she just
She used
forget?
a competitor.
I'm sorry. Yeah, right. And she didn't get the email from Express Scripts. And so there's an adherence problem. Or she filled out that manual form, which is a testament to the failing of healthcare. It's filling out that 18-page form when you go see every physician or you visit the hospital. And she only admitted to have 2 narcotics prescribed by specialists. It turns out she's on 4 narcotics, and if I prescribe another one, I could have a drug interaction and kill your mother. I mean, that's accountable care. That's reducing data to actionable information and intelligence at the point of clinical thought.
Thank you. And Louise, with the new healthcare legislation, many consumers think that healthcare is reformed nationally, but all of us in the industry know that healthcare happens locally. And how can we engage local communities to take what the federal healthcare legislation has put forth and implement and integrate locally?
That's a really good question. I think sometimes there are people that think, oh, now it's fixed. We passed the legislation. And I think all of us in this room know that that's just the beginning and that a lot has been happening since then. And so we have the incentive and the motivation, and the reform helped create sort of this unprecedented opportunity. But it really will take all of us, working together, using information, but really taking it back to our own personal situations or the sphere of influence that we have. And so I think there's about 30 or 40 groups like the Midwest Health Initiative in communities around the country where all the different stakeholders are coming together and using information and their partnerships to sort of connect that. So we know that in every community, and certainly in St. Louis, we have a lot of wonderful work going on. There's a lot of great nonprofits and other folks out there focused on one piece, but they don't always get the attention that they should get, or they don't always get connected or the right types of resources. So if we can help share information with all of those groups and have some way of keeping them connected and people informed, negotiating, if you'll do this, I'll do this, or what is the shared commitment, what are we all willing to do, and then sort of holding people accountable for the commitments that they make and kind of monitoring and tracking our progress over time. But it will take a lot of people working together to make that happen, community by community.
And then one last question before we open it up to the audience. Dr. Miller, there's a huge issue in the United States today with regards to fraud, abuse, overuse of pain medications. It would seem that pharmacy data and pharmacy data systems might be able to help impact that, especially with As you mentioned earlier, once you merge with Medco, if that goes through, you're going to have pharmacy records for 100 million people. What is the status on that, and what is Express Scripts doing specifically around those issues?
Yeah, it's a really interesting problem. As you know, it's the use of OxyContin and other narcotic pain medications in the United States is truly an epidemic that's adding a tremendous financial burden, not just to the healthcare system, but also to the justice system. When you have visibility to the data like we do, we actually are able to work with the DEA and shut down fraudulent pharmacies all the time, because we can actually develop bell-shaped curves for both patients, pharmacies, or physicians, and identify those bad actors who are disproportionately using. The biggest problem, though, and this actually gets to a big problem for everyone in the room, is that when you have no visibility to the data, you can't fix the problem. When it comes to narcotic abuse in the United States, the vast majority of nefarious use of narcotics is paying cash, which means there is no claim that's ever generated. So it's never seen outside of that store. So the patient can't be identified, the store can't be identified, nor can the physician be identified. So we actually have a proposal that we were up on Capitol Hill with. We actually think it's very easy to fix because it's all based on what we're talking about today. If you have the data, you can fix the problem. But without the data or the visibility to the data, the problem can't be solved. And so it's germane to what we're discussing today, and that is you have to have the free flow of quality data to make differences.
And with that, we're going to open it up to the audience for questions. There are mics on either side. If you could identify yourself and then ask your question. If you'd like to direct it at a specific panelist, please do so.
Thank you for your presentations. My name is George Trubelitz. I'm a state epidemiologist, and I work with data often. We talked a lot about how important it is the data to be timely, and that's extremely important. We talked about the quality of the data, which is extremely important, but something I wanted to mention is if we take all these databases we have in Medicare, medical knowledge, academia, and start releasing it to the consumer, it has to be done responsibly. Mm-hmm. And the reason I say that is there's going to be ever another private company that will try to dumb it down even more to make it more accessible to the consumer. And dumbing it down, you're going to get to the point when information is not usable anymore, and it's actually, we create the monster because we're going to create the nervous wreck out of consumers. And let me illustrate. For example, let's say today, this morning, you get up and you hear on the radio, which has actually happened this morning, that the prostate cancer is up in St. Louis County 20% compared to national average. I don't know, I have to see the study myself. Maybe it's true, maybe not. But somebody who is not really knowledgeable in study designs and things like that, he reads that and, oh, I got a headache. I need to take maybe Tylenol now. But I just saw that website that Dr. Park was talking about. There was a recall on Tylenol in Alaska. Maybe in St. Louis is also bad Tylenol. What can I do? I need a drink. But wait a minute, Dr. Oz said that there is arsenic in the water. Maybe, no, I cannot handle this myself. I have to go to the hospital. Then I go to hospital rankings. My neighborhood hospital is no good. There is another one 30 miles away, but the gas is $5 a gallon. And my insurance wouldn't let me go there. So you got a completely frustrated consumer. He's bombarded all this information. Half of it is probably irrelevant and not useful for him. But most consumers, believe me, I deal with this, are not educated to handle this kind of information. So how much we want to release, what kind of information we want to release, and who's going to control all this? Market will decide which one is good, which one is bad after we created the nervous wreck out of consumers? I don't know.
Would anybody like to take that question, Louise?
I enjoyed your analogy, and I think we all understand there's some truth in that all this information can be really challenging for consumers. And when I go there, I'm first comforted, and again, I mentioned a meeting I was at last week. CMS and others are doing a lot of great research in how to make this information meaningful and useful for consumers. But it also takes me back, and it'll show my age, to when we thought about putting labeling on food. And we said consumers won't care. They'll never be able to understand this. They don't want to know what's in their food. You know, how many times a day do we all look at the back of a package and know what's in it and understand it? And so somehow we got through that and we figured that out, and nobody would think about going back to the days when we didn't have information on the back of food. So my vision that gets me up in the morning is that someday I'll be an older person, which I am now, and I will see some young people using healthcare information to make a really good decision about a treatment choice. And I'm going to get so excited, and they're going to look at me like I'm from Mars and say, "You mean we didn't always have that information?" And so I think we're so close to it right now, and we haven't had it, we can't vision it, but I think we're getting there.
Anybody else have thoughts?
Yeah, what I would add, just to comment, and speaking to an individual that helped launch the largest healthcare consumer and community site, WebMD, a lesson learned from that is that medicine is complicated, healthcare is complicated, and we can't expect consumers to become doctors. We really can't. And as far as changing behavior, I mean, we actually know that if people smoked less, maybe drank a little less, and didn't eat so much, that healthcare in the country would improve dramatically. More power to all those that are trying to change consumer behavior. We think there's a big focus on the trusted advisor and changing the behavior of 350,000 physicians who drive about 80% of the healthcare costs in this country, sourced from their decision making, that if we can influence the physician who has the capacity to absorb this information, distill it, and communicate it, giving them the right tools to do so, to consumers, we've got a better short-term opportunity of improving healthcare outcomes. Longer term, obviously, consumers have to become more accountable. But we believe a big focus near term on the physicians is important.
Next question over here to the right.
Oh, no, I think, go ahead.
Oh, sorry.
No, that's all right.
I'm Linda Cooperstock. I'm the public health planner from Columbia Boone County Public Health and Human Services. And I am very intrigued by the amount of pharmacy information, pharmacy data that is collected. And I wonder if you have any suggestions on how we can bridge the gap between that data and public health information to improve the services at the health departments. And for example, what I heard was that you can tell when people don't complete their prescriptions, and maybe that helps us implement our program of pharmacy assistance. So I'm interested.
Yeah, no, it's a great question. So we actually partner with researchers and clinicians all over the United States. So we have a research lab that actually does work with particular projects. Obviously, we only have a certain amount of capacity to do that, but we currently have pilots going on with all sorts of organizations, including WashU, St. Louis University here locally, but also Duke University, Harvard, and others. And so we even do it with community health agencies where there's these compelling projects. I'll give you a great one we're doing in Louisiana right now. We actually have decided to identify which doctors are the most potent at getting their message out in the community. So in Baton Rouge, we actually took the 150 biggest prescribers, made calls on them to see if we could influence their prescribing habits and move them to generic medications. In New Orleans, which was matched for population and socio-demographics, we actually just called on a handful of doctors who were the thought leaders as identified by Christakis's modeling of networking. And sure enough, just calling on a handful of doctors had more influence than calling on the high prescribers. And so you can use, so we do these experiments all over. So when people come to us with good experimental designs, we're very excited to participate.
So when we talk about data use and its applications, and I think particularly on this panel, I'm curious about your thoughts and opinions on transparency and its role in terms of aligning incentives and motivating and changing provider behavior. I think a lot of things we talked about today have focused on sort of consumer applications and consumer digesting data or information and influencing consumer behavior, but nothing seems to work better in terms of bending the curve in healthcare than actually changing the way we pay hospitals and physicians, or putting certain dollars at risk, or penalizing, some ways to look at it, certain types of performance. So I want to kind of hear your thoughts on where we stand, or what should we expect to see in terms of transparency and financial payment reform as it applies to data?
Michael?
Well, it's a big deal. I mentioned earlier around behavioral economics. I mean, we've kind of gone through a national denial that behavioral economics applies to healthcare. And we mostly criticize the payers, the suits, for, taking money out of the system and not adding value, and that providers are all well-intentioned and they're there to help people and they'll do what's right for the people without consideration of their own personal economics, and we just think that's wrong. But that's mistaken. The history of mankind suggests otherwise. So an example of changing reimbursement and payment and aligning incentives is the more socially acceptable term.
That's right.
Is actually paying providers to provide better care. And pay them, if you want preventative care, pay providers to provide preventative care. Why would you, as a non-provider, do it without being compensated for it? There are people in this world who do things, Clara Barton and a few people in our history that did things regardless of economic outcomes, but they're far too rare. Let me give you an example of, I mentioned earlier, the era of big data and the ability to actually influence physician behavior at the point of clinical thought. In the future, one of the things that we do, and I think others do around predictive modeling, we have something called the patient care profile that we present at the point of patient care. And it does a superb job of retrospectively educating that physician on what's going on with that patient that's presented to them at that particular moment. We're now focused on prospectively forecasting the trajectory of morbidity for that physician's panel, at the individual patient level and at the panel level. Now, why is that important? Because we believe that some physicians want to make $1 million. We also believe that some physicians want to make $250,000. Now, this is kind of, some people are going to get a little anxious now based on what I'm saying. But the way the healthcare system should respond to that opportunity, and we think it will, is that we actually want to deliver more care to the chronically ill. Because we know that if we deliver actionable care faster in the diagnoses, that will actually lower the overall cost and produce better clinical outcomes. So there's some physicians that should only want to treat the sickest people in this country, and they're going to give them their cell phone numbers. They're going to work 24/7, and they want a population that is very sick. And we should pay that physician or that provider for taking care of those chronically ill people and producing better clinical outcomes. And maybe it's worth $1 million to the system because they may save us $5 million by being proactive and incentivized. But then there's other physicians that may say, I want more of an 8-to-5 job. And I really want to treat mostly the well. I want to do more preventative care. I want to treat well people with colds. And I'll take a few difficult cases, but at midnight, I really don't want to be my cell phone to ring and it's chronically your mother calling because she's had a drug interaction. And maybe the system that person gets paid $250,000. So this is a case of lining incentives with information to essentially allow that physician to decide how they want to practice medicine.
Any other thoughts?
Yeah,
Louise?
I would just add that obviously transparency is extremely important to the business community, and I think also to consumers. And it's something that, it's hard to understand why we don't have it by now. I think the points that you mentioned earlier about the economic impact of healthcare and the downturn in our economy and the challenges and the variation we know that exists in cost and quality, it is hard to understand. We believe very much that what gets measured gets improved, and what gets reported gets improved faster. And we really need to pick up the pace of improvements and believe very strongly that more disclosure of differences in the cost and quality and the treatment effectiveness of care will make a huge impact. And so we want the federal government, we really appreciate what they're doing. We want them to go a little bit further and help us get full transparency in all communities.
We have a question over here.
Yeah, my name is Shaker Prabhakar. I'm with a company called C8 Software.
Could you actually step a little bit closer to the mic?
Yeah,
Thank you.
C8 Software Consultants. And first of all, I want to say, when Todd started his meeting, he mentioned about Bill Joy. That's a company I worked for before, Sun Microsystems. So it was really nice to hear that. Great company. But my question is, when we are talking about data, pretty much whoever has the data has the control. I mean, no matter what anybody says. That's how in the companies, data warehouses are built and everybody goes to that particular group. So with making this data available and with EMR, many of the large companies or providers, they are able to invest better into technology tools, business intelligence, and whatnot. So I'm just going to go ahead and compare it with Amazon. When Amazon started, it was very small. But as they started having that open APIs for any vendor to go ahead and provide them the services, and as they were able to build this big data warehouse, other bookstores, many of the bookstores, as you know, has gone out of business. So with putting this data into big corporations, are you going to hurt the small providers, or what it is going to be?
I'll take that. So, I think you bring an important issue, and one of the things in markets is that, people succeed by delivering a better mousetrap or better value. And in healthcare, because we haven't had good information, sometimes we've seen that the people that are able to profit the most, perhaps, don't always have higher quality, or some of the folks that don't have the same pricing power have just as good quality as others. And so we know that quality isn't tied to price. So I have some concerns that there'll be winners and losers, and that some of the people that might be losers might be the folks that are doing a really good job in terms of delivering value. And I think that is something we need to think about as society and as health systems in our communities, that we're really attuned to this idea of winners and losers, and that the people that fail may not be the folks that are delivering a lower value. They may just not have the pricing power. I think, though, information can help, and if we can really get the information out there and they can demonstrate high quality, that's a better opportunity for them. I do believe that when we brought the Midwest Health Initiative data together, the idea was to make data a commodity and to make it, everybody share a little bit of the cost and the burden in putting it together so that so many people in the community can use it, and so that we don't have this disadvantage with some people that have more money having more data than other people.
Okay, I think we have time for one more question.
I'll try to make this very quick. It's actually more looking for suggestions, but then as well to issue a challenge to this panel as well as the previous panel. My name is Kelly Gertzkin. I'm from Jefferson County Health Department, and data is a big part of what I do every day. I write grants, and so information that I need to be able to make my case for the need within our county, a lot of times we find very difficult to get. We're just big enough that we can get countywide data, but we're just small enough that we can't get the county or sub-county level data, which would help us to make the case for the different populations. We consist of Arnold, which is very similar to St. Louis County, but then we have the southwestern portion of the county, which is extremely rural and low income. And in order to make those kinds of data available to you, I've been reaching out to partners within the community in terms of traditional partners, our hospitals, our health clinics, but then as well to the resources, such as the Parks Department for walking trails, working with obesity epidemics, and different partners along those lines. We have a lot of partners who are willing to come together with the data that they have, but being a small department and a local community, we don't really have the financial wherewithal or the knowledge to put together the data systems, to collect it, to make it usable for people within the community. So basically my challenge to you is, as you're looking at the data systems and as you're creating the federal level, the state levels, and down, think about the local communities that can use the data and that really would be able to pinpoint specific areas and make a very big difference in the health of their citizens. Thank you.
Thank you.
Can I make one comment?
Yes.
I just want to say, so you're a perfect group that we'd like to see use the data that we have in Midwest Health Initiative. And we do have the ability to break out county level data and other sorts of things. And so would love to get your card and see what we have today that we can help you and how we might be able to help you in the future.
Great. And with that, I want to thank our panel. Thank you so very much for your insight, your advice, your feedback. I think it was very telling. It was good to hear the trends, and it seems things are really moving in the right direction, that there are a lot of opportunities with this new transparency and this new liberation of data. So with that, I want the audience to give our panel a round of applause. Thank you. And then with that, I'm going to ask Mr. Holland and Mr. Park to come up and conclude our program. Thank you.